Hello, my name is Jill Barnholtz-Sloan and I'm from Case Western Reserve University School of Medicine. I want to thank the conference organizers for having me here today to speak with you about nomograms for individualized survival prediction in brain tumors. I do not have anything to disclose, nor do I have any conflicts of interest. Brain tumors contribute disproportionately to mortality in all age groups, as is shown here in this figure taken from the Central Brain Tumor Registry of the United States 2019 annual report. Therefore, it is critical for us to better understand mortality and survival for brain tumors in order to help patients. We've known for a long time that Karnofsky performance score, age at diagnosis, extent of surgical resection, histological type of brain tumor, and treatment pattern all impact prognosis for brain tumor patients. In addition, we now have validated biomarkers such as MGMT methylation, IDH mutation, and 1p19q deletion. However, in general, we discuss groups of patients when addressing survival, and the statistic that we use is median survival. But as we all know, not everybody is at the median, and it is a distribution of patients, and there can be wide variety. So why use a nomogram? A nomogram is an easy-to-use tool where you can look at the particular factors for that patient and use that information to actually estimate individualized survival probabilities. Our group has published multiple nomograms, including 2 nomograms for glioblastoma, a nomogram for brain metastases, and a recent nomogram for lower-grade glioma, which I will talk to you about today. So some items to consider when assessing a nomogram are the following. And as I go through the examples that I'm going to show you today of some of our nomograms, these are important items to keep in mind. First of all, what's your sample size? Do you have a robust enough sample size to truly estimate survival with confidence, including multiple different factors? What about internal versus external validation? Of course, the most powerful model is one where you have external independent validation of your final model. But many other nomograms that are published use internal validation as well. Which modeling methods were used? Why did they choose the final method that they did? And how did they compare the models to each other? These are also important things to keep in mind. Many times the models are compared using receiver operating curves and area under the curve statistics, and also something called a C index or concordance index. What about the calibration curves for the final model, which compare observed versus expected values? Do they match up well or do they not match up well? And sometimes these calibration curves can be greatly impacted by sample size and study power. And then, of course, we have to think about, will it really be useful clinically? And we would all love for our work to be useful clinically. So now I'm going to go through a couple examples of some of our recent nomograms for you. We published a nomogram looking at IDH wild-type glioblastoma patients only, given that the vast majority, about 95% of glioblastoma patients are IDH wild-type. And I think this group is well aware that if you have the IDH mutation and you have a glioblastoma, your prognosis is very different than those that are IDH wild-type. And so we focused only on the group of patients with IDH wild-type glioblastoma. We define glioblastoma by the International Classification of Diseases Oncology version 3 typical codes that are used, that are listed here. And we put together 2 independent data sets that were taken from the same years of diagnosis on newly diagnosed glioblastoma patients who were at least 18 years of age at diagnosis. One was taken from our study in Ohio called the Ohio Brain Tumor Study with a sample size of 179 patients. and the other was taken from a cohort of patients from University of California, San Francisco, with a sample size of 122 patients. We used 3 different types of survival modeling and then compared those models using C-statistics and calibration plots. And we used standard Cox regression proportional hazards modeling. We used random survival forest modeling, which allows you to, in an unbiased fashion, model as variables and their association with survival. And then also recursive partitioning analysis, which is a standard analysis that's been used for many years by some of the clinical trials consortia, such as NRG, etc. Our final model ended up being based on the Cox regression model because this model performed the best according to the C-statistic comparison between that model, the random survival forest, and the recursive partitioning analysis. Our final model, this is what a nomogram looks like. Our final model included age at diagnosis, sex, surgical resection, whether or not they had concurrent radiation temozolomide, Karnofsky performance status, and MGMT methylation. And the way that these models are used is for your patient, you would record their value for each of these different variables, and then you would look on this scale and figure out how many points were assigned to their value. And then you add up all the points for those variables, and then you use those total points to then assess a predicted 12-month, 18-month, and 24-month survival probability. Now, it's not really practical that in this form, this could be used easily within the clinic. So we developed an online tool, very easy to use, using Shiny, R Shiny. For those of you that program in R, the Shiny app through R is really a wonderful interface and allows you to create these online tools very easily. And so this is showing you an example for a 65-year-old male, greater than or equal to 70 Karnofsky performance status, who had total resection, unmethylated MGMT, and concurrent radiation temozolomide. You can see here the number of points that they were given for each variable. So their total points here, and then their predicted 12-month, 18-month, and 24 months survival. And so hopefully you can go here and check it out. Here's the web address. And this was also published in Neuro-Oncology Advances in 2019. I want to switch now to our nomogram for lower grade glioma. Very similar approach that we took with this analysis as with the IDH wild type glioma, a glioblastoma nomogram. Again, we use the International Classification of Diseases Oncology version 3 codes to define lower grade glioma, and this was used for patient selection only. For the training data, we used the Cancer Genome Atlas data on lower grade glioma, but we merged the data from the paper that was published in 2015 with updated survival outcome data from the pan-cancer analyses, which allowed us to obtain the most current patient outcomes for follow-up time and survival status for those patients. The validation set that we used was taken from our Ohio brain tumor study with overlapping years of diagnosis to the Cancer Genome Atlas project, and both data sets focused on those 18 years and older at diagnosis. Here again is the example so that you can see exactly how the nomogram looks. In this case, our final nomogram is grade, age of diagnosis, sex, Karnofsky performance status, which molecular subtype they were. There are multiple molecular subtypes that are of prognostic significance for lower grade glioma, and they include IDH mutation and 1p19q deletion. We again developed an online tool using R Shiny. This is showing you an example for a grade 2 lower grade glioma in a 60-year-old female with a Karnofsky performance score of 90, and they were in the IDH mutant CODEL subtype, which is the best subtype, and they received a low number of points and therefore had very good 60-month, 90-month, and 120-month predicted survival. Some of our most recent work is focusing on sex differences in brain tumors. And we know that there are incidence differences between males and females. Males get gliomas more often than females, although females get meningiomas more often than males. And some of our recent work has shown that, in fact, even after adjustment for treatment pattern, that females have better survival. And we really don't understand the reasons why. So we've gotten access to some data sets, a training and validation independent data sets from NRG, and we're developing sex-specific glioblastoma nomograms, so stay tuned. This is a team effort. I wouldn't be anywhere without our team and our funding. We're very grateful for that. And thank you so much.